Good afternoon, everybody. Bonjour à tous. Welcome to the first of 3 webinars Born Ontario is hosting this month to learn more about their readiness survey to collect and use social demographic and social determinants of health data. We will refer to this data as SD and SDH data or as health equity data. My name is Pascale Girouard-Frappier, and I'm the Regional Coordinator for Prenatal Screening Ontario, housed at Born Ontario, and I'm delighted to be your moderator today. I will also be joined by Alicia St. Hill, Executive Director at Born Ontario. Health equity is everyone's business at Born and infuses every sphere of our work. I'd like to start by acknowledging the 17 members of Born's internal Health Equity Advisory Group, whose contributions have made the dissemination of this survey and today's webinar possible. For today, we encourage you to enable the Q&A feature located at the top of your screen and post your questions as we go. And with that, let's dive into today's session. I would like to start by sharing a land acknowledgement. Acknowledging territory is only the beginning of cultivating meaningful and reciprocal relationship with First Nations, Inuit, and Métis peoples and communities. Nous rendons hommage à tous les peuples autochtones de la région et de toutes les nations à travers le Canada qui considèrent Ottawa comme leur foyer. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. J'aimerais débuter en reconnaissant que la terre sur laquelle nous nous rassemblons est le territoire traditionnel des peuples Haudenosaunee et Anishinaabe, le peuple original de l'île de la Tortue. Reflecting on this land acknowledgement, Born is aware of and seeks to adhere to the principles of Indigenous data governance and supporting Indigenous sovereignty with access to information and health data. Safe self-identification and the use of such data must first involve building relationship with Indigenous people, communities and organizations, and supporting their information health needs. Throughout this survey, we hope to learn more about the efforts of our data partners in supporting Indigenous wellness and data governance. Ontario Health continues our consultation around Indigenous identity data collection. Therefore, they do not yet propose specific wording for these questions and answers at this time. We recognize these data as part of a whole person's identity, and we acknowledge that these are missing in the current guidance. And we are asking in today's survey, how would you or how do you approach collecting Indigenous identity information? So you may be wondering why the survey we shared with all of our data partners earlier this month asked many questions regarding the organization's current SD and SDH data collection and use. We have invited you today to ensure we share the context behind this initiative and provide you with the following insights. Why are we launching into the collection and use of SD and SDH data? What insights are we hoping to gain from the dissemination of this survey? And also a few tips on how to fill the survey. Further, we want to discuss how we intend to use the results of this survey. And finally, we want to answer your questions regarding the survey and this initiative. Further, we're excited to be joined by care partner guests, Manavi Handa from Reach Midwives, as well as Aideen Reynolds and Geneviève Mosher from Ottawa Public Health, who will share with you their own journey with the data collection and how this data is used to improve the delivery of care in their own communities for equity-deserving groups. We will be hosting 2 more webinars where other guests will also share how these concepts are being brought to life in their own community. Let me now introduce you to Alicia St. Hill, Executive Director at Born Ontario. Thank you, Alicia.
Thank you, Pascale. Hello, everyone, and thank you for joining us today. I'm Alicia St. Hill, Executive Director at Born Ontario, and it's a privilege to be here with all of such a dedicated group of professionals interested in advancing equity in Ontario. Born was established to collect, interpret, and securely share high-quality data that informs care, from system planning to individual care decisions. And as a prescribed registry under PHIPAA, we work across the continuum of care with many partners. This broad reach helps us reflect families' lived experiences and identify gaps and inequities in care. Prenatal Screening Ontario, or PSO, is a key part of our program. Originally focused on screening for genetic conditions like Down syndrome, The labs that are performing multiple marker screening, testing that's done by over 70% of birthing individuals in Ontario, have provided us some rare racial sociodemographic data. While imperfect, that data has helped us to start to apply a racial equity lens to the care and outcomes analysis we performed. Its limitations, however, highlight the need for more inclusive data that reflects Ontario's diverse population and the intersecting identities, including language spoken, newcomer status, race, housing and financial security, disability, and gender, among others. But today's effort to learn about the use of SD and SDH data goes beyond data collection. It's actually about connection. The N in BORN stands for network, and that's exactly what we are. A collaborative, province-wide network of programs, clinicians, researchers, policymakers, and data partners. And together we've made meaningful impacts in care and evidence generation. And as we continue using health equity to guide our improvements, we'll ask new and sometimes uncomfortable questions, uncover disparities, and build solutions that close these gaps in care, because the outcomes we seek must be attained by everyone. Equity isn't a side goal. It's central to our vision, best possible beginnings for lifelong health. And today's conversation and our accompanying survey are steps that we're taking to make sure our data and our systems and the way that we measure care and outcomes reflects that truth. We're aware that organizations are at different stages when it comes to health equity and collecting and using this data. And that's great. In fact, our own journey at BORN has been long and nonlinear too. In 2012, we began with the launch of the BORN Information System, or the BIS, a new platform that was going to bring together data from multiple existing sources and programs. We collected information about primary language and education level and a few other SDH items, but placed limited focus on completeness or capture at the time. Early in our journey, we also engaged with more than a dozen Indigenous health partners. And in these conversations, we listened for and heard how a registry can evolve to better reflect traditional models of care, support self-identification of Indigenous ancestry, and uphold Indigenous data governance principles. These insights help shape our thinking about how data can support and serve communities, and not just systems. Internally, we've built and sustained a culture of reflection and psychological safety with our internal health equity advisory group. Formed in 2020, this multidisciplinary team helps us stay responsive to the diversity of the birthing population in Ontario. And we encourage our team to grow their understanding of health equity concepts, Indigenous sovereignty, reconciliation, and data governance, how to apply an equity lens to analyses, and strengthen the policies that guide our work. In 2021, we were pleased to strengthen the advice that we receive from people with lived experience and expertise outside our program to the creation of the External Health Equity Advisory Group. In 2021 and 2022, BORN researchers published studies showing racial disparities in perinatal outcomes, even after controlling for other risk factors. These findings sparked new insights and hypotheses, and as we continue to examine outcomes across socioeconomic and sociodemographic lines, including recent work that we've done on postpartum mortality, we're increasingly aware of the limitations in the existing data. But publishing alone isn't going to be enough. We're increasingly aware we're going to have to be committed to bringing people together to understand why these differences exist and to measure the impact of the interventions. And we're actively building capacity internally to do that. Through recent work with our Ontario's pediatric diabetes education programs, we've learned from local teams how to safely and meaningfully collect social determinants data from children and youth. This work is shaped by thoughtful engagement with care teams and families and ensures that the process is respectful and secure. Early feedback from one center already using this data has shown us that it helps to tailor care in meaningful ways, reinforcing that even just the act of collecting and asking these questions and gathering this information can lead to better experience and outcomes. To improve outcomes for all families, though, we need to understand the broader context of their lives, not just the biology and the administrative data, but the social, economic, and cultural factors that shape health and life in Ontario. This represents a culture shift. It challenges us to move beyond the traditional approaches and recognize that access to care isn't equally distributed and there are numerous barriers to best outcomes. We must ask not only how many are receiving excellent care, but who is not and why. For clinicians, Sociodemographic information, especially when safely self-disclosed, helps tailor care to the real and perceived risks and needs of patients. If we ask patients to share their food insecurity concerns, clinicians and care teams are better positioned to help them navigate available perinatal nutritional supports and resources, and allowing our care models to respond to and anticipate proactively and address issues that influence pregnancy outcomes, like low birth weight or high bleeding risk from anemia, with bleeding being the #1 cause of postpartum death, still in Ontario. For programs, both local and provincial, we can use SD and SDH data to allocate resources and tailor our programming based on our populations who come through our care settings. For example, if we see higher rates of preterm birth from preeclampsia among certain racialized groups or in specific neighborhoods experiencing higher levels of deprivation, those insights can drive our collaborations that tailor our outreach, our awareness campaigns, prenatal education, screening, and other services in collaboration with the community. It's that kind of data-driven coordination that's going to help care reach those who need it most and ways in which they can best access it. In multiple marker aneuploidy, or the fetal genetic screening I mentioned earlier, we actually use race to adjust for biomarker differences observed between populations. Our PSO program is doing a deep dive to understand how these adjustments continue to affect screening outcomes. But lab requisitions only tell part of the story. Richer intersectional data must come from elsewhere to help us better understand the differences driving the use of race, as race may only be a proxy for other underlying factors that affect screening performance more directly. Community organizations, for example, Indigenous health organizations or community-based parenting programs, all and some already do use SDOH data to ensure services are culturally relevant and supporting key health issues. As Ontario expanded its RSV protection program for infants last year, understanding who makes up that approximately 25% of children who will remain unprotected after discharge from birth hospital and the social context that surrounds them and their families means that future seasons are going to help us tailor our approaches to better in partnership with clinicians and community to be responsive to the family's perspectives, values, and beliefs that may be affecting their participation in these programs. These kinds of approaches build trust and improve engagement with care, and we look forward to our work in partnership with ICES as we use our RSV data and additional sociodemographic information already collected about individuals, and including newcomer status that's available at ICES to give us better insights into the equity of that program. Researchers, including clinical and social science researchers, also use published insights to further explore disparities. Beyond the medical correlates, it can help to shed light on what some of the mechanisms, structural inequities, and discrimination may be at play in perinatal mortality and morbidity. And above all, we collect and use this data to drive accountability. Without it, inequities remain invisible, silent, poorly understood, and unaddressed. With an equity lens, we can track progress, identify gaps, and hold ourselves accountable, ensuring that equity isn't just a goal, but a measurable outcome. And the uses of our insights extend far beyond the health system. Many of you here today know that health is influenced by more than what occurs within our traditional healthcare settings. And where external factors are at play, like in many of the real-world examples I shared, it's our responsibility to raise them up as opportunities for improvement with government and others in position to better outcomes for life's very beginning. We've launched a survey to understand how practices and organizations across Ontario are engaging with their patients and clients to collect and use SDSH data. And whether it's being asked and collected aligns with what was proposed in Ontario Health's guidance on collecting and using SD and SDH data that was published last summer. You've received a copy of this with your copy of your survey. This will inform our work ahead, and we thank Ontario Health for their leadership in making that resource available. Today, we're invited to join, and we're glad that you've joined us in this learning opportunity. Whether you've already completed the survey or just learning about it, we're glad you're here, and to hear from partners who are on the journey with us. Your survey responses will help us take a pulse on current activity and readiness across sectors, with the survey being shared with midwifery practice groups, birthing hospitals, and public health units across the province. Inform next steps in our own data collection, governance, and use at Born and PSO. Help us identify leaders and champions and early adopters who can support this peer learning and network building that we need to make important steps in these endeavors. And understand where support is needed. to encourage the adoption of the leading practices for how we ask, collect, use, govern, and engage individuals and families in what we learn and how we can better support them. We hope it'll also fuel some partnerships. Beyond those who are presenting today, the aggregated results are going to be shared with all of you, our partners, and including the Equity, Inclusion, Diversity, and Anti-Racism Group at Ontario Health and the Provincial Council for Maternal and Child Health, who are both focused on this work too. And we hope that it also helps us explore meaningful use and perhaps novel and new data exchange options for prenatal, postpartum, and primary care settings. Some of the work we planned in the near future will use our unique registry authority at Born to directly impact care and outcomes with digital health solutions that reach individuals and families and their clinicians with the goal of improving the safety, care engagement, access to timely, personalized health information, and insights. These same digital tools, though, may be used to support private and well-governed sociodemographic data collection directly from individuals and families that can be used both in patient care and health system analyses. We've also asked questions in the survey to help us better understand how you or your practice might envision using SD and SDH data that patients or clients wish to share with you, but that comes from external sources. Thank you so much for joining us today and for the time you've already taken or will take to tell us about where you are on this journey. Pascale, I'll send it back to you as you provide further overview of the survey.
Thank you very much, Alicia. If any of you have any questions for Alicia, please feel free to share them in the Q&A section. The survey we've shared with you was developed through various community and partner engagement opportunities. So last year, as Alicia mentioned, Ontario Health published their guidance document on SD and SDH data, which helped us shape the survey. And after piloting, we simplified the survey based on the feedback we received because it was initially way too long. And so the topics shown here reflect the survey structure. Sections 1 to 5 are for all respondents, whereas sections 6 to 10 appear only for organizations working towards or currently collecting SD and SDH data. The first question asks whether your organization collects the data, who collects it, when, how it's stored, and what barriers might exist, such as perhaps limited resources or a lack of leadership buy-in. And here are a few sections we'd like to highlight. Data governance, section 5. We ask whether receiving SD and SDH data from other sources would be helpful and how your organization approaches governance. This helps us understand readiness to manage and ethically use sensitive data, as we know strong data governance is essential to build trust with patients and communities. In section 6, collection content, we're curious whether your organization uses Ontario Health's 2024 guidance. Disuse of this guidance may support consistency and standardization in our data collection efforts. So even if you're unsure, you will have the opportunity to upload your questionnaire directly in the survey or email your questionnaire directly to us for our team to review. In the community engagement section, section 9, we want to learn how community leadership is involved in your data journey and whether frameworks such as EGAP or Engagement, Governance, Access, or Protection, a framework published by the Black Health Equity Working Group, or OCAP, copyright by the First Nation Information Governance Center, were considered in your efforts. This helps us support other sites in deepening community engagement. And finally, in section 10, we're interested in how the data is used or intended to be used to drive meaningful changes in your community. The call to action from communities has been loud and clear, and that's why we're thrilled to welcome our afternoon's guest speakers, who are not only passionate about their work, but are making a real impact in their community. So to start, please join me in welcoming Manavi Handa. Manavi is a registered midwife in Ontario and practicing for almost 25 years. An award-winning midwife and activist, she's most noted for her impact on midwifery care for undocumented and uninsured immigrants. She's currently an associated professor at the Toronto Metropolitan University and practices at Reach Midwives. Manavi, thank you for being here and for sharing the work that you do.
Thank you so much for having me. It's a real pleasure to be here. And thank you for also dealing with my slides, because just so people know, the Born side is going to be forwarding slides or moving my slides forward because I don't have access or couldn't upload. can we go? Okay, so just to give you a bit of context, when I'm talking about the collection of SDOH data, I'm talking about it within the context of one of the places where I work, which is the non-insured walk-in clinic. This is a walk-in clinic that is run through Access Alliance Multicultural Health and Community Center, and Reach Midwives. We are the midwives who see all of the pregnant walk-in patients who come. And now we do a bit of expanded kind of reproductive health care also. So the context in which we're collecting data is actually data that's already been decided that the community health center wants to collect. Okay, we can go forward. So just talking a bit about how the data collection works. And I think this is really a place where technology could come in very handy. So people fill out this very large form, which you'll see in a minute, as part of their clinic registration process. So where they put their name and like, you know, address and that date of birth information. They also fill out like a 2-page form that includes a lot of socio-demographic information. All clients are required to fill out the basic information, but most fill out the whole form. And so they get the form on intake, they have to fill it out. Then they give it to the admin person registers them, but probably doesn't put in all of the SDOH data. Then that client is seen at the walk-in clinic, but we have enough info for like a lab sticker or whatever we need. Later, another admin person puts in the rest of the SDOH data. So it's a pretty labor-intensive process. And in every step of that, one is sometimes there are interpreters available, but often there aren't. And English is not the first language for many people, and many don't speak English at all, certainly don't write English. And so filling out the form, if you speak English, probably would take a good 10 to 15 minutes, 20 if you're proficient in English, but not as your first language. And at every time the data is input, and we've just finished a 10-year data collection, which is why I can share some of this information. Every time it's input, there's more chance of error from what the original form said. So I think that's kind of an important thing to think about. And I would say most people fill out the form. Okay, we can go to the next slide. So what are the problems? As I said, English is a big issue. There's often an on-site interpreter for a few hours of the clinic, but they're more needed for actual clinic appointments. So they might be in the registration area available to help. I don't know if people know why the data is collected. And so I was thinking, like St. Mike's years ago had this program called We Ask Because We Care. And I was thinking it might be helpful when collecting SDOH data to kind of use some kind of familiar terminology so people realize it's because you want to improve their experience that you're collecting the data. It's not punitive. And I say that especially because I work in a world of people who are undocumented. I think with tech, it could be easily fixable. Like I don't see why clients don't just get a tablet and we use some kind of AI translation. Like it just seems like it would be simpler and have less error. And so that's just kind of a lesson that I've been thinking about. I mean, really, I think the idea of tablets would seem expensive until you realize how much admin time goes into the collection of SDOH data. And to be honest, this is an organization very committed to the social determinants of health, but I can see why, if that's not your aim, it would be considered really cumbersome. Okay, next slide. So they do pretty robust data collection. So there's 6 categories: insurance, socioeconomic, language, background, disability, and well-being. And I'll go into some of those in a little bit more detail. So the next slide. So gender identity where I would say here with gender identity and sexual orientation, the both boxes on the left, the language is really dated. And I would say that that is one of the challenges, I would say, is as we understand the complexities of identity and intersectionality, how do we keep up as we evolve in our thinking so that things don't become dated really quickly? And I think this is an ongoing challenge as language changes and norms change and our understanding of experience changes. So you'll see under sexual orientation, there are kind of many fewer terms than what I think we would use now. So that I think is a really good example of an area where things get dated quite quickly. Going to the education, we ourselves were not really sure what university, there's a category, there's university, bachelor's, and college, and we just realized that in lots of places in the world, university is called college, and so it's a bit of a confusing terminology, but otherwise I think that one's pretty robust. Certainly what we found in our data was, and we've just done like, this is barely looking at our data, we've just collected it, is realizing that there weren't a lot of surprises, like demographics that we know tend to have lower levels of education. That was reflected in who we saw also. Okay, next slide. I'm trying to go fast too, because I know we have other people. So income, you know, I was surprised initially that we started so low, and I would say, like, I was like 0 to 14,999 for a household. Like, is that a thing? And yet, I would say 90% of our clients reported a household income of less than $20,000. Only one out of 1,350 charts had an income of over 60,000. Everyone over $25,000 were permanent residents, and that speaks a bit to our system and how permanent residents have to have more economic stability in order to get their papers. It's also, you know, obviously there's the question of, are people honest in this or not? I don't know why they would be dishonest, because we have nothing to do with any financial kind of assistance that anybody could get. But I do recognize that we're also talking about a population that's very precariously employed. And so is household income really accurate? Definitely, I think homeless status, I think the language needs to be changed, but I think we also need to consider precariously housed people. And we didn't anywhere in here collect food security. So I think that would be something that would be really important also. Household composition. Now, obviously, there are a lot of different options, but I think they do a pretty good job of collecting kind of the different versions that households are made up with. Okay, we can go to the next slide. So definitely, and this is where especially around language and our understanding of intersectionality is important, there's a lot of Indigenous focused language that I would say is missing. So they didn't include Inuit, they didn't include any kind of Indigenous groups from Central or South America, people from Australia, Pacific Islanders, Eritrea, like, so, and I think one of the lacking places is that there's a place for mixed heritage, but there's nowhere to identify with more than one thing. So there are people who identify as Métis and Black, but we just say you're mixed. We don't let people kind of pick multiple things, if that makes sense, which I think in our world would make much more sense if people could choose more than one category. The definitions were very Western, and I found it interesting. I mean, we have a fair number of people from Central and South America because you can get here from those parts of the world. But it was interesting to me, for example, Brazil, which is kind of known as, one of the areas in the world that has lots of cultural mixing. The number of people who would write Brazil or Brazilian with exclamation marks as almost like a protest to the categories that we had. And so I thought that was interesting. Okay, we can go to the next one. Disability, I mean, some people did write pregnancy under others, so that was kind of interesting that, people saw pregnancy as disability. It was very interesting to me, and I think it was great that we asked about sense of belonging to community, and I think that, I really like that wording. And it really varied from very weak to very strong, and that might have to do with what kind of heritage groups people are part of. But what I also thought was really interesting is they asked about this people's self-assessment of their physical health and their mental health. And the vast majority said good or very, very good or excellent to both. And I think in some ways that probably speaks to the healthy immigrant effect a little bit. Like, we know that if you're young, you're healthy enough to get pregnant, so you're presenting with pregnancy already, that says a good amount about your health status in a way. And so, we know there's an idea that immigrants when they first come tend to be healthier. And so is this more common earlier on? And it would be interesting to see, like, if we had people fill this out over time again, like 5 years later, would it change? Like, we don't do that, but that would be really interesting. Okay, next slide, and then I'm almost done. So the surprises, I would say, is how many people fill out the form. I certainly think I would be more impatient with it, especially if I didn't understand the language that it was written in. One of the kind of interesting surprises is there is this new trend that we're seeing that really became apparent in our research of Mexico and Brazil are like the capitals of the world in terms of cesarean section rates, especially within the private sector, but now also in the public sectors. And there's this new trend, and I always think where cesarean's most common, these trends start but spread pretty quickly, where women are being cut from their umbilicus to their pubic bone in a straight line instead of what we call a low bikini cut. And they'll get the low bikini cut. It's called the cosmetic cut now, if they have money to pay for it. So not only are they being horrifically scarred, but once you are cut that way externally, we don't know how your uterus is cut. And that puts you in a totally different risk category around where you might want to decide to give birth and how you might want to decide to give birth. And so it's putting all of these, like a good proportion of our uninsured clientele, in a higher risk category automatically. Just a reminder, I mean, I think the level of poverty was a surprise in some ways, maybe not in others. I think that was all. Yeah, those were the main points. I think there might be one more slide. Oh, so I mean, we've just done this 10-year data collection. So how we've used the data and what's happened in the past. So definitely the Community Health Center has used it to develop targeted programs. So one of their big programs is something called Health with Dignity, with the understanding that marginalized communities often are not treated well in our healthcare system. I certainly think for REACH midwives, we could utilize the data to inform programs like prenatal classes in Spanish and Portuguese in particular, vaginal birth after cesarean classes, so that people who've had these cesareans can decide for themselves and help determine for themselves what kind of incision they think they might have had. There's kind of a series of questions you can ask that make it quite clear. And maybe even a session or some kind of information to clients about hospital payments and how that works, so people realize every time they interact with the hospital system, they'll get a bill. And then just I think if we could implement something, it would be tablets for people to be able to fill out the information. And that is it.
Thank you so much, Manavi. I think you certainly shared a lot of really great topics to help us think about different things. I would like to now invite Aideen Reynolds and Geneviève Mosher from Ottawa Public Health to join us. So
Hello.
Aideen, oh, go ahead, Aideen. I'd like to
Hi there.
introduce you if that's okay.
Sure.
Aideen Reynolds is, I'm gonna go to my slide, is an knowledge exchange specialist with Ottawa Public Health. She has over 20 years of experience working in health equity in academic, community-based, and public health settings. Her current role focuses on advancing the collection and use of SDD within OPH and contributing to standardizing SDD collection among local, regional, and provincial health system partners. She's accompanied by Geneviève Mosher, who is a nursing project officer for Ottawa Public Health with 20 years of dedicated nursing experience in maternal, infant, and family health. Her extensive expertise encompasses both hospital and community health settings, where she has made significant contribution to the Healthy Babies, Healthy Children program. In her current role, she plays an important part in supporting sociodemographic data collection aimed at enhancing client-facing services for families with the Healthy Growth and Development Program by effectively addressing barriers. Aideen and Geneviève, thank you for being here.
Thank you. Thank you so much, Pascale. And thank you for the invitation to share our experience with all of you today. Before we get into the presentation, I just want to start by acknowledging the clients who are trusting OPH with their sociodemographic information, and also want to echo and acknowledge OPH's Healthy Growth and Development team for their leadership in this work at OPH. They really are leading the charge at our organization, so just want to acknowledge them. And I also want to thank Pascale and Bourne for the land acknowledgement. Geneviève and myself are joining from Ottawa, which is located on unceded Algonquin territory, Anishinaabe territory. And I want you to know that OPH is collecting SDD on behalf of Indigenous communities in Ottawa, and we're committed to following OCAP and other Indigenous data governance principles that keep ownership and control of the data with the community. As far as an overview, so what we'll share with you today, we'll talk a little bit about the current environment as far as enablers and frameworks for SDD collection and use. We'll talk about the SDD journey at OPH at a very high level, and then Geneviève's going to walk us through sort of how we've rolled this out in the Healthy Babies, Healthy Children program, and we'll wrap up with some lessons learned and what things to share with the group here today. So listening to you earlier, Pascale and Alicia, and you've made mention of some of these documents already and this guidance, but in the public health context, I'm not sure how many public health colleagues we have here today, but monitoring health inequities is foundational to public health. So you see there on the left, that's a model from the National Collaborating Centers for Determinants of Health. And it shows public health roles that include assessing and reporting inequities in populations. So these public health roles and the focus on health equity are also reflected in the Ontario Public Health Standards, seen there on the right. And these outline the requirements and minimum expectations for public health units in Ontario. So there's very clear guidance sort of that suggests the need for this work. Where it gets difficult is having the systems to actually capture the information. So there's an expectation that we are assessing and monitoring and addressing inequities, but having the systems to actually do that are sort of where it gets challenging and where we're pushing and trying to advance the work. So just a little bit more here in terms of background. We see alignment with guidance from Ontario's healthcare sector. And so there was already mention of this health equity, inclusion, diversity, and an anti-racism framework, where we clearly see there on the middle circle, that upper left puzzle piece, collecting equity data is a key area of action. And then on the right, this has also already been mentioned, but the guidance from Ontario Health for the collection and use of STD for equity analytics. So there's very clear alignment with kind of the direction that the province is going, and other leaders. As far as our journey, we had actually started piloting STD collection before the pandemic, but it actually got a real boost during the pandemic when health units in Ontario were mandated to collect from people who were diagnosed with COVID-19. And I don't need to share with this group, I'm sure everybody's aware that when we did that, we found inequities. So we did see that COVID-19 was impacting disproportionately certain members of the community. So then coming out of COVID, we're looking to build on this work. We launched a policy for STD collection and use that was intended to communicate a clear commitment to this work internally and externally with partners. The image on the right is our conceptual framework that emphasizes the importance of community and relationships throughout all aspects of this work, starting from deciding whether STD is even an appropriate tool or whether it's needed, right through analysis, disclosure, and getting to being actually able to share and use the data with partners. So just continuing to center the community voice there. And so in that way, we want to ensure that we're honoring principles of data governance, particularly with Indigenous communities, as well as with Black and other communities in Ottawa. And this requires that meaningful, ongoing engagement with community. So continuing to build internal and external support, our strategic plan 2023 to 2027 has a specific objective to advance STD collection and use in front-facing services. So that's been very helpful just internally to set that expectation. Related to that, we developed a resource page for employees to learn more about STD collection and to support implementation of that new STD policy that we were rolling out. And then we also produced public-facing resources, such as the brochure you see there on the right of the screen, to explain to clients, why we're asking for this information, to help with that trust-building piece that happens between the provider and client. This is a busy slide, but basically this table gives you an overview of where and how we're currently collecting. The program areas are listed down the left-hand side of the left-hand column there, and the rows are color-coded to depict the status. So the top 4 orange rows reflect work that is now finished, where we've finished collecting, we've analyzed, and that's considered complete. The green lines or rows are actively collecting, and the last 2 yellow rows are in planning stages, and we do have a few other areas that are in planning stages. The how column shows the method of collection. So we work with teams to adapt to their unique workflows and implementation context, and to learn from the teams what information the program wants to collect and for what purpose. And so while the method of collection might vary from one team to the other in terms of the process or the procedure, we do strive to ask for the information in a consistent way, as recommended, as our policy recommends. The question wording and response options are consistent and informed by best available evidence. So such as that we ask because we care work in Toronto, but also CI-HI, also the Ontario Health Guidelines as well. So we're anchoring in those best practice guidance documents. When we talk about this work, we often use these two bigger buckets. So there's on the left, the orange bucket is everything that goes into thinking about whether we're going to collect SDD, planning, to starting to collect. And then once we started collecting, then the gray box or bucket is all the work related to monitoring completion, looking at data quality improvement, analysis, and then finally being able to share and engage partners, and hopefully engaging partners throughout, which is why we have that box in the middle as a reminder that we should be engaging community in sort of across. And if you remember the framework, across those 4 stages of collecting through to analysis and use. The bidirectional arrow also suggests that it's not linear, and there's often we're going back and forth, like it's not a 1, 2, 3, 4, 5, 6, and there's often we're going, once we might have already started collecting and we're looking at completion and noticing that the data is not very complete, then we have to go back and revisit the procedure and perhaps make some amendments or add something. Some other supports. So that's just to suggest that it is fluid. It's not a one-directional kind of process. So I'm going to hand it to Jen to talk about SED collection in the HPHC program. Go ahead, Jen.
Thank you, Aideen. Thank you. So the next slide, please. Perfect. So now we'll take a closer look at how our Healthy Babies, Healthy Children program is doing, and it is collecting this information. So to start, the referrals are usually received either from our hospitals, so either from hospital staff or from our hospital liaison nurses from public health who are in hospitals every day, or they are received from our community partners. And families are usually screened during using the Born screening tool at the bedside when they are in the hospital. And one of the ones are identified with needing additional needs are referred to our Healthy Babies, Healthy Children home visiting program. So during the first home visit, families will receive an in-depth assessment and the SED is completed. And families with a positive IDA will be offered the long-term home visiting program. Next slide, please. So the SED was started with our program in late 2022. So it is voluntary and with the informed consent from the clients. An Ottawa public health nurse or a family home visitor will ask the SED directly from the client during a home visit. And this can be either a parent or a caregiver. And we aim to collect within the first 4 visits, but ideally the first or second visit is the best scenario. The data is collected and entered in a secure Microsoft web form with the family file number. So there's no other identifiers, there's no client name or date of birth. And there's an option to collect this information during the home visit on paper and then to transfer later in the computer in the web form. So as a visual aid tool, we have created this form in different languages. So at this time, it's available in Arabic, Simple Chinese, Spanish, Hindi, and French and English. So sometimes it is helpful for clients to kind of look at the form in a different language and follow along with the questions. And you'll see in the slide on the right, there's 12 fields that we are currently collecting. For the last, if you see the last 2 at the bottom, you'll notice that our team is now requesting information on for immigrant status, and depending on other services that they may need. For example, if they don't have access to a regular care provider, we are able to support with this if we know this information. Next slide, please. So since we started collecting, 50% of our clients have been involved or invited to provide an SDD. And of those who were asked, 91% consented. So we're getting some great interest in receiving this the SDD. And at a high level, these findings are really validating what the nurses are seeing in the front lines, which is an overrepresentation of new immigrants, the need for other languages other than English or French. There's a lot of housing instability and shelter use at the moment, and there is a need for mental health support. And also, many do not have a healthcare provider, so which is a key determinant of health. So we are seeing this information, and this will help to improve the situation down the road. Next slide, please. So to get to a point of being able to use and share this data with the community, we planned a community dialogue in October of 2024. And this was to find out how can this information and data be used, and who would benefit from having this information, and who needs to know, and to hear about any risks there might be to sharing this information. So we had more than 30 participants included in the meeting, and organizations who work with new and expecting parents, and we included some HBAC clients as part of this community dialogue. And we shared a summary of our findings and talked about how OPH is using SED, which including things such as increasing the diversity of languages spoken by our staff, prioritizing mental health and training for staff to be able to cater to the needs of our clients, engaging partners. So, for example, housing and shelter use, so we're able to collaborate with our Ottawa housing partners in order to help the situation. We're also able to liaise with local OHTs to attach people to primary care providers where possible. And also we're able to tailor support to clients who are immigrants. So I'll pass it back to you, Aideen, to continue the presentation.
Thanks, Geneviève. So just to wrap up, a few things we've learned. Success requires a slow and steady approach, and particularly the way we're working, where we're tailoring collection by team, it is very resource intensive. So I could really relate to what the previous presenter was talking about with the resource intensive, but particularly when we're kind of tailoring by team or by interaction. Depending on the program and what questions you want to answer, SDD may not be needed or may not be the right tool. So there may be other equity data that can answer the questions that the program has or that the organization has. We've learned that teams need time and tools to feel comfortable asking for SDD, and training helps to build provider comfort and confidence to know how to respond to any questions that the clients have about this initiative. And then, of course, establishing comfort also applies to clients. They need to feel safe and understand why we're collecting this information and how it will be used. So informed consent is key so that clients understand they may choose to decline or prefer not to answer, and that it will not affect their care. That is so important. Our experience has been that when SDD are collected and analyzed, inequities are identified. And with that analysis piece, we need to handle these data with care. Community needs to inform and control how we use and share the data in ways that advance health equity and do not harm communities. So particularly, in all work, but public health work, we work with, infectious diseases, and we really need to pay attention to what we're finding in the data, and really, we do not want to cause harm to communities. So how do they want to tell their story? What's their experience? And it is their data to share. So the importance of ongoing engagement. Oh, this is key. The importance of ongoing engagement with teams to encourage collection. So they like the teams that are doing the collecting, like hearing about how the data is being used in programming and decision making. So conversations with the people who are actually collecting the data creates buy-in and ultimately yields better data. So for example, my colleague and I have been invited to the Healthy Growth and Development team meeting annually, where we go and we talk about completion, like how complete is the data and what are we finding? And the team is the one that said, can we ask about primary care providers? Can we ask about immigration status? And the most recent one is, and we're working on a question about food security. So I agree with the previous presenter, but the team is actually asking for this information. So it just shows us what that how that engagement can really build that buy-in and garner interest in this work. So thanks. I think I've got a couple more slides, 2 more slides. Okay. In terms of lessons learned also, OPH co-led a Public Health Ontario funded LDCP project, so a locally driven collaborative project with Peel Public Health and Upstream Lab. And this was to document the public health experience collecting STD through COVID-19. And what we see is that the findings reflect the common themes similar to what we've shared today. So this, you're going to see, if you look at what was found with our peer health units, it's very similar to what we've shared today. And you can look at those links on your own time. And then finally, just a note about data systems. Back in 2022, OPH led an ad hoc working group of 9 public health units to identify a standardized set of STD fields to recommend to the province for inclusion in database systems. We reviewed existing tools and best practices and reached an agreement on 14 STD constructs to recommend to the province for inclusion in public health reporting databases. So AFIO, the Association of Public Health Epidemiologists of Ontario, and ALPHA, the Association of Public Health Agencies, endorsed the recommendation. And this visual above is a letter that was sent to the Ministry of Health asking for these standard, the inclusion of these standard SDD in data systems. And I guess what we just want to say is we're delighted that BORN is moving kind of in this direction and advocating for kind of better data and systems that will collect this data, and looking to capture this important information from our clients, our people. And that's it. Thank you so much.
Thank you so much, Aideen. Thank you, Aideen, Geneviève, and Manavi for coming and sharing these insights with us. Thank you for the work you're doing. I would like to turn the floor to people in the audience with us today. This is the time to ask some questions to people from BORN or from our presenter. Feel free to post some questions in the Q&A section if you would like to share your questions with us. If some questions come to you later after you have finished this webinar, please feel free to share your questions with our equity email. You can find it right here. I'm just going to give a few minutes to see if people have some questions they would like to share with our presenters today. You have the equity email here on the slide. Please feel free to take note of it to refer to it later if some questions come up. It's really been a pleasure hosting you, and we hope this webinar has provided you with the appropriate information and context to fill the survey regarding your sites. Prior to logging off, if you could take just a few minutes to fill a few short questions regarding the survey, it would really help us improve our webinars going forward. You can scan the QR code here on the screen. And we're wishing everyone a wonderful rest of your day, and we're excited to continue collaborating with our partners. Thank you, everybody. Thank you to our presenters.
Thank you.
Thank you.
Thanks, everyone.
Oh, Erin, we have one question from Erin. I saw a hand up. Is she? I'm not sure if she's still here. Maybe she's left. So feel free to submit your question. We'll make sure to get back to you. Thank you, everyone.